Hello, welcome to our presentation, Social Work as Critical Coalition Building. My name is Melissa Guadrón and my co-presenter is Guadrón Teston. We're from the Ohio State University. And we're gonna start with this quote from one of our participants. I think the clapping for healthcare workers was a very interesting thing that we were doing as a society, where I was kind of like, I wish you would just give us hazard pay.
The rhetoric of health and medicine, or RHM, is technical and professional communication's sister discipline, according to Hannah and Arjusar. We heed Natasha Jones's call to, quote, engage with issues of injustice, inequality, and dehumanizing forces. Specifically, we conducted a mixed methods investigation of how healthcare workers practice human dignity during COVID-19. Our results highlight how one allied health profession in particular regularly confronts injustice, inequality, and dehumanization, and that is social work. Our findings suggest that social workers' backstage labor embodies what Licona and Chavez term relational literacies. According to the authors, quote, relational literacies are understandings and knowings in the world that are never produced singularly or in isolation, but rather depend on interaction. Being relationally literate means that someone is capable of bearing witness to and then making legible, quote, for the purpose of shared social action, end quote, another's story or experience. In particular, social workers do their jobs by building coalitions that anticipate and mitigate mistrust between clients, colleagues, and the myriad facets of the US healthcare system. Social workers in our study employed coalitional approaches in an effort to respond rhetorically to the economic conditions that enable racist, gendered, and ableist healthcare in the first place. Frequently acting as brokers and glue, social workers in our study confront class-based hierarchies while building trust with and advocating for underserved populations. Additionally, as self-described jugglers and firefighters, social workers are often called upon to fulfill the basic needs of their interprofessional colleagues in response to gaps in support from employers. For the next few minutes, we'll provide examples of social workers' relational literacy, a series of examples of what Licona and Chavez refer to as a kind of convening. Then we will make an argument about how RHM researchers must adopt a critical coalitional approach to understanding how allied health professionals, such as social work, confront injustice, inequality, and dehumanization, both horizontally and vertically. In other words, RHM researchers who partner with allied health professionals, such as social workers, need to be mindful of the often well-intentioned desire to romanticize the care labor that such workers enact. Such romanticizations risk reifying neoliberal notions of care.
During our investigation, we conducted interviews and focus groups with 13 social workers. For the purposes of this presentation, we highlight the contributions of 2 social work colleagues who participated in the same focus group, Pamela and Terry. Our data demonstrate how social workers, 1, build trust among clients who may have some form of distrust of the medical industrial complex, and 2, compensate for the structural failures of employers by providing coalition and care to their interprofessional colleagues. The following excerpts illustrate how Pamela and Terry, as social workers at a large nonprofit hospital in New England, act as brokers, glue, firefighters, and jugglers, addressing the needs of patients, families, and hospital care teams. In response to being asked if COVID-19 affected their definitions of dignified care, Terry told us that professionally, her definition had remained the same because, quote, I think that's what we do as healthcare workers and especially social workers. We just kind of jump in. It's like a fireman jumping into a burning building. It's just almost, could be TB, it could be COVID, it's just the next thing. And I think we're all trained for that, end quote. Later, when asked how she would articulate a definition for dignified care, she gestured toward patient-centered care. Quote, I think of it in terms of their needs, put your own needs aside and ask them what's important to them. Acknowledge what's important to them, if it's their culture, if it's your religion, and honoring whatever wishes, not forcing your beliefs on them, honoring whatever is important to them and respecting that, end quote. In her response to the same definitional prompt, Pamela drew our attention to the ways social workers negotiate larger systems in which clients and patients are embedded. Quote, it's like acknowledging, who your patient is, what they want, honoring those things, and then also acknowledging sometimes what the patient, the way that our systems either support or don't support that, and how we can work together to try to support that as best we can. Because I think oftentimes, we can understand someone and really advocate for what they need, but unfortunately, our medical system doesn't allow for whatever it is that they need, or our, housing system or whatever system, I think. Part of human dignity is acknowledging and honoring, like, our society is failing you and you haven't failed. Like, you aren't the failure. It's the society or the systems that are failing. I think it's important to always bring that into these conversations because I think it's often missed. And then people start to feel like, oh, I've done something wrong. When it's like, no, our society just isn't structured to support people appropriately, end quote. And in this exchange between Pamela and Terry, they highlight the complexity of caring for patients who, as a part of the US healthcare system, are embedded in a host of dehumanizing cost-benefit analyses. When asked if they had received explicit training on how to provide dignified care to patients, Pamela told us, quote, I think with COVID, we're seeing a lot of like, oh, well, it's just old people who get sick. So, and I think that really speaks to the idea that we don't necessarily value the human dignity of older folks. And I feel like it's very similar for folks who are using substances. There's not really like a value and dignity kind of given to them from society because maybe they're not, contributing to capitalism in the way that, we would want people to, or society wants people to. And so I do think that's an interesting thread. I think overall, kind of the social work lens can lend itself really well to kind of being rooted in dignified care. But I think it's really interesting to think about, what are the other populations that we work with that can kind of bring that out more? And are they populations that are valued in society or not? And are they populations that, typically are given dignified care and basic respect or not? To which Terry responded, I see a lot of alcohol withdrawal, drug addiction, that kind of thing. And you bring up an excellent point. I mean, these people are marginalized and, a lot of healthcare workers hate working with these people. They just, they've got a stroke victim, a car accident person, emergency department. And then you've got somebody in for the 5th time in a month detoxing. A lot of medical staff are just, they get fed up. So that's something that I didn't get specific training on. And, I felt at a loss when I was working in an emergency department that, I had to kind of learn myself to pull back. And I was the one telling people, look, this person speaks Spanish. That's why they can't go to AA because there are no Spanish speaking groups in their community. So I feel like I even told the social workers, I was really disappointed that other social workers weren't, having their back. Like if a social worker can't defend a patient like that, who's going to stand up for them? More specifically, Pamela gave a focused description of how social workers, in trying to provide mental health resources to patients, are forced to negotiate with the larger systems in which their patients are embedded. Quote, I'll have a patient who's homeless and really depressed, and I'm like, do you want therapy? And they're like, no, I'm homeless. I'm not going to get less depressed unless I have housing. And I'm like, yeah. And, we talk about the ways in which the housing system has failed them. And, why in the hierarchy of needs, you wouldn't necessarily be able to do therapy unless your recipients are mad. And with COVID-19 has come some additional barriers. When asked about how COVID-19 has affected their caretaking practices, Pamela shared, quote, it's really difficult because if you, as a patient, are in the hospital, your random, phone in your room rings and it's some social worker calling you to talk about your substance use. And you're not necessarily going to want to talk to them or feel safe to talk to them. And especially if you have any distrust of the medical system, like appropriately so, because the medical system can be really hard to trust. And so I think it's really changed the way that I work with patients and the way that I work with families. And I tried to be much more animated over the phones so that they even feel more engaged and more supported. But that's hard because it doesn't always come off that way. Taking up the subject, Terry added, quote, "It's just created this huge barrier. And like everybody else has been saying, it's, social workers like to touch. I like to touch people. I would have just given her, a client, a big hug normally, and I can't do that. I can't. I would never just grab her and hug her, but I would say, is it okay if I hold your hands? Is it okay if I, give you a hug?" But I mean, that's traditionally what I would do. I like to be, open and warm with people. And I don't know if that's a dignity issue, but I certainly keep thinking glass wall. It's this COVID thing is like a glass wall between us and the care we can provide because you can only go so far, end quote.
And finally, we think it's important to zoom out from the patient-social worker relationship to understand the ways in which social workers are being tasked beyond the normal boundaries of their jobs. When asked about the degree to which they believed they were being supported by the larger systems in which they worked, Terry revealed a surprising responsibility she had taken on. Quote, "I bought 300 masks and brought them in and gave them to my nurses. They weren't even, there was nothing, there was no guidance, nothing at all. And I don't want to throw them under the bus and give their name, but I think a lot of the caregivers, the nurses, everybody was calling me for some reason. I was the social worker. And even when it came down to PPE, I was giving the nurses PPE and telling them to wear it. Nobody from above was telling them to wear a mask. And because I'm a germaphobe, and I would do that even in flu season, I bought these masks and I made them. I gave them to the certified nursing assistants and the nurses. And I said, here, you have to wear this. And so there was nothing, no support, no direction. For some reason, I was the one everybody called. Pamela clarified that she didn't feel supported by the hospital. In fact, she hesitantly defined the response of her hospital and much of America as a form of gaslighting. Quote, "They think, there's a lot of, I don't want to call it gaslighting, but I guess that's kind of what it is. This sort of like, well, don't you want to help? This is a safety net hospital. Don't you want to do everything you can for everyone?" And sort of this almost expectation that you can kind of give too much and have no boundaries at all. We've had to take on a lot more, just like everyone's had to take on a lot more, but it was almost expected that we take it on and be boundaryless and do whatever we want. And to the point and do what everyone else wants, to the point where we basically had a mass exit from our department. We had at least 20 people, I think 15 to 20 people leave, some per diem, some full-time. And it wasn't because of COVID people went to other hospitals, but it was more because of the way things were being managed. We've gotten lots of kind of, free treats and these fancy snacks and stuff like that, but no hazard pay or no real guidance on PPE until May of 2020, or, things like that. So I think it's been really interesting because they're trying to kind of manage things, but then also doing a lot of gaslighting and a lot of, well, you signed up for this, so you should be okay, to the point where so many people left. So I think it's been really interesting to think about the ways, systems can support healthcare providers because, and I don't know how to move forward, but I know the system I'm in right now is not the one that's supportive. We leave our viewers with the following recommendation: that RHM amplify the work of allied health professionals as critical coalition building by embodying what Linden and Lydahl call a, quote, double vision of care, which involves a Harrowingian effort to, quote, stay with the trouble. Critical coalition building frames care as more than one, a space that invites critique, or two, a heroic and selfless act that recognitions thereof tend to overshadow the systemic failures that force such heroism. Right now, Melissa and I are grappling with how RHM collaborators can at once amplify allied health professionals' under-recognized and under-resourced care labor, without further treading the well-worn path of a neoliberalized care cul-de-sac that, due to failing networks of state-sponsored social support, ends up reifying individual actions as the primary, if not only, means by which care is practiced.
We'd like to end our presentation with the following questions. How, if at all, can rhetoricians partner with folks like Pamela and Terry to push back against and/or more clearly navigate what's happening? Coming full circle back to how we began this presentation, one of our major takeaways from the social justice turn in technical communication is the recognition of how genres and professional systems exert power. How can rhetoric health and medicine scholars partner with allied health professionals to push back against or critique such genres and systems? For comments or questions, we can be reached at guadrón.1@osu.edu and teston.2@osu.edu. Thank you so much for your time.